Try now.
Okay, is that better?
Oh, I saw nods.
Okay, you can hear me?
Can you hear Miss Penola in the back? Say that again.
Can you hear me? Everybody, can you hear me? Okay, I'll just try to speak really loud.
You can't see your face.
Oh, they can't see me. Okay. There, can they see me now?
No. Maybe if you just remove that. Oh, okay.
I'll just bring it down.
Okay.
Okay. Okay. All right, like I was saying, our sign to our treatment facility, we're a small treatment facility. We do outpatient treatment. But the sign says Wa'okia Oti in our Lakota language, and it means helping TP. And that was created by one of our elders that passed away from COVID last year. His name was Jay Taken Alive, and he was one of the counselors at the treatment program, and he started a sobriety run back in the 80s, and it lasted until maybe the late 90s, and then he went on to be one of our councilmen. Our reservation was established in 1873, and it straddles both North and South Dakota, so that sometimes can be an issue. Our treatment program, we have 9 employees, myself as the director. I've been the director for 2.5 years. When I first came aboard, it was like 2 months later, then the pandemic hit. So I had a lot on my plate. I also have Carmen Goodhouse. She's our program manager, and she's been working there for 40 years. So she is so helpful to me. Carol Sanders, she's our woman counselor. Leroy White, the men counselor. Rhonda Sandland, our intake counselor. Mike Littlebear, the data coordinator. We don't have an adolescent addiction counselor right now. That position is open. We've also got 2 SAMHSA grants that I'm very thankful that we have. We have the Youth and Family Tree Grant, and I am the project director for both of those grants as well, those projects. I have Selina Steele, she's a family coordinator, Corrine Ironshill youth coordinator, and then Rosalind Treetop, we hired her as a peer support person. I have Rochelle Ironcrow, she's a licensed addiction counselor. I brought her on through a consultant agreement because we needed another addiction counselor due to the rapid amount of clients we get that need assessments. I have Brooklyn Maxon, she's an outreach coordinator, and Marie Shoestring, admin assistant. Those 2 work for the Tribal Opioid Response Project. The Standing Rock Treatment Program originated in 1971 as the Standing Rock Alcoholism Treatment and Prevention Program. And back then we offered detox. It was built in the town of Fort Yates, and it was right next to the hospital, so they could offer those detox services, which we really need now on our reservation. The Standing Rock Treatment Program provides adult and youth addiction programming, which includes evaluations, placements, individual counseling, aftercare. We provide other addiction services based on our clients' needs. Our mission statement is the mission of the Standing Rock Treatment Program is dedicated to promoting a healthy lifestyle, restoring balance and harmony in mind, body, and spirit to the Native American adults, youth, and their families. Oops. Can't go on here. In March, like I said, I was hired the beginning of February, or the end of February, and then March 2020 and COVID-19 hit. And so I just kind of want to elaborate on the pandemic and how it started, and then toward the end, go into MAT. We were given administrative directives that, travel was restricted, and that really impacted our programming because we refer clients to inpatient off the reservation. And so that really greatly impacted our services for inpatient care. We were directed that travel was restricted. We could no longer travel out of the reservation. We couldn't allow people to travel in. I believe I strongly believe that our tribe handled COVID-19 effectively, and immediately. They developed an incident command team, which included my supervisor, Margaret Gates. They did a wonderful job. They brought in the National Guard. We did mass testing immediately. We had to develop our COVID policies, all of the programs on the reservation. Then we decided to do telehealth. So I had to develop telehealth policies, and then we implemented telehealth and developed the processes. One of the processes is what we mailed out. We depended on the mail to get out our intake packets, our consent forms, our releases to clients. We mailed it out. Once we received it back, then we contacted them for services, and it was all telehealth through telephone and through the internet, Zoom. We also, with COVID dollars, they purchased all of the employees' laptops and cell phones so we can work remotely. We never closed our doors. We continued to work because our telephone lines continued. We received 20, 30 calls a day from clients wanting evaluation, wanting services. And then mass communication, we had to get out to the public how we were operating. And so we went on the radio. We used social media campaigns. We used email to get our services out to the public, what we were offering and how we were offering it. Another thing that our administration implemented was temporary public health emergency leave. If any employees were tested positive for COVID, they didn't have to use their vacation leave that they worked hard to build up. They created emergency leave for families. The COVID emergency leave policy was established. And then they established the COVID-19 remote work or workplace safety policy. So all doors were closed to the public. And then we had, all the COVID, like the spit guards, all of that safety precautions. We had automatic temporary temperature checkers at the door. All of that was really helpful in infectious control. Our telehealth services, we implemented them. It wasn't as smooth and as quick as I wanted it to be, on our part and on the client's part. A lot of our clients, they have minimum, they don't, one of the difficulties with working telehealth on our reservation is that, a lot of our families don't have the higher income, so they didn't have devices. They didn't have access to the internet. But we were able to work with our tribal council, and they got wireless services out to the public in our community buildings. Our reservation has 8 districts, 8 communities that are sparse. Yeah. So in the community buildings, they set up free internet for the public to go there and access services, whatever they needed. We also went door to door, and we handed out flyers on telehealth and on harm reduction techniques. Here's some of the flyers that we used, that we passed out in the communities. We even went to the casino and we put them on all the vehicles. We went to all the communities and we handed out flyers on how we were continuing services. We also started different programming on social media, and this was one of them. It was the Good Medicine Time, and this was for the youth and families to come on. And it was like a 9-week session, and each session there was a different topic for families, and it was attended well. This is our client flow chart that we developed, and we presented that to the public as well. You know, once they come in, they're assessed. If further evaluation is needed, you know, down the diagram it went, you know, onto case management. If they needed treatment, if they only needed education, then we directed them to get prevention education. MAT on our reservation, we have one doctor in our Indian Health Clinic on the North Dakota side. Her name is Dr. Brittany Bearstail. She is certified in MAT. She has 2 case managers, and they've been averaging 10 to 15 patients. On the South Dakota side, in the Indian Health Clinic in McLaughlin, South Dakota, there's 2 providers, Carlita Aberly, a nurse practitioner, and Callie Aberly. There's also 1 nurse down there. We also have 1 pharmacist who is certified to distribute naloxone, and they also distribute Narcan. Anybody can get Narcan at the pharmacies. Some of the pros and cons to MAT that we've experienced is getting the client stabilized while minimizing the risk of relapse. You know, a couple times a week we get clients coming to the treatment facility, going through withdrawals, wanting treatment. And we explain to them that they need to go to the emergency room or contact Dr. Bearstail and receive that medical treatment first, get that medical assistance first, and then once they get stabilized, then we can conduct the eval or assessment and go from there. Another thing is the lack of supports for our clients: housing, income, transportation. A lot of the clients that we serve, they come through the CPS system or the court system, and they've lost everything. They've lost their kids, they've lost their homes, so they come with nothing. And during the pandemic, it was hard to serve them, mail them the packets that they needed, because they were living with a family member and they weren't on their mailbox. So then, you know, the mail we get returned, that was difficult. Also transportation. You know, a lot of them lack transportation. Our program, we only have 1 GSA vehicle, and we try to designate that just for the use of transporting to inpatients. So transportation is always an issue. The other support systems create a high expectation for success. We get a lot of family members that call, a lot of mothers, grandmothers. They call and say, my grandson, my niece, they need treatment, you know. And there's a lack of understanding of MAT. They think, you know, once they get on MAT, they should be automatically cured or automatically stabilized, whatever. And then there's also the belief that MAT is used as a crutch. It's, you know, using the medical, the naloxone, you know, using that as just switching vices, you know. They don't believe that. There's just a lack of education to the public. Another issue is a lot of belief that it's an easy way out to using another substance. not making the necessary changes in their life. And the common attitude that complete abstinence is the only true way to recovery. You know, we get a lot of people saying, well, you're just, like I said, they're using the naloxone, just trading vices. You know, that's the belief that we face. And then another issue, another challenge is many inpatient facilities that we refer our clients to, if they're on a naloxone, or they do not accept clients who are on Suboxone, sorry, because they lack the medical team to follow up or to monitor. Here are some of the pros. It improves patient survival. Between 21 and 22, I believe we've had like 3 overdoses on our reservation. It also increases retention in treatment. You know, the clients will do better in treatment with that support. Clients can gain or maintain employment in school. You know, we have a lot of clients that are trying to maintain their job at the casino or through the court system. So MAT is a good resource for them. It also decreases criminal activity, increases positive birth outcomes for pregnant women. Naloxone is safe for pregnant women. We've gone through some training, and that was one of the things is, you know, it's safe for pregnant women to use. Relief from the pain of the debilitating withdrawal symptoms. Like I said, we get a lot of clients, you know, 2 or 3 a week that come to the facility and they're just going through withdrawals real bad. And so we just refer them to the ER. We refer them to Dr. Bairstill and her team. It also reduces the potential for relapse and curb or reduce intense drug cravings. We received, in 2018, we received the SAMHSA grant, the Tribal Opioid Response Grant. And through the ATTC website, we received some training, and then we use a lot of the resources on that website, which I'm very grateful to. I was able to hire a tribal opioid response outreach specialist, and that was Brooklyn Maxon. I got that job description from the ATTC website, the Addiction Technology Transfer Center. I got the job description and we took it to council. They approved it and I was able to hire her. She is responsible for providing outreach in the community to educate tribal elders, leaders, other tribal members, including the population of focus and relevant others about the availability of the Tribal Opioid Response Project and related services and recovery supports. Brooklyn Maxon was working with the MHA tribe. It's one of the tribes in North Dakota. It's north of us. And she was instrumental in developing their prevention program. They have sober living, they have all these other preventions. So I was glad to have her come aboard. She's helping us develop that. We're hoping to use one of the COVID grants, the COVID trailer homes that was purchased by our tribe, now that they're not being used for the COVID isolation. We're hoping to develop a program and get approval from tribal council to use one or two of those trailers for sober living. That is, you know, something that we really need, and we're hoping that, you know, all of that falls through so we can start a sober living program on our reservation. The The outreach specialist also utilizes the knowledge of the population of focus, develop or contribute to development of a logical, safe, targeted outreach plan to engage participants or referrals of participants and provide presentations at tribal community meetings and relevant events. One of the things that the ladies on my team did is they went out to all 8 districts and they gave up Narcan, and they gave a Narcan presentation. They also hit up the high school before prom and before graduation. They went to the high school and gave presentations on Narcan, even, you know, driving drunk, because, you know, that's what they do on prom and graduation. So they were able to do that on the North Dakota side, and the South Dakota side is attend those schools and give those presentations. Here's some other programs that we started on Facebook and social media. Brooklyn started the Tribal Opioid Response Team page, where she, you know, publishes upcoming events in our communities. You know, even the powwows. We've also started attending all the powwows and setting up a booth, setting up a table. We purchase the prize wheel and we take it to the powwows, and, you know, we give out drug education. We have them spin the wheel, and we give out an incentive. And then every Monday she has the recovery roundtable, which was really well attended. She has different folks that are in recovery come and tell their story on her Facebook Live recovery table, and it's been well attended. You know, all the lights. Using social media and Zoom, we've been keeping track of our data. That's one of the things for our SAMHSA grants, is we always have to have that data. And so our tribe had a social media policy before the pandemic that we weren't allowed to be on social media. We weren't allowed to, you know, address anything on social media. But because of the pandemic, it was kind of a saving grace, or I don't know how to say it, but we were able to use social media and provide some of that programming. And it was an easy way for us to keep track of data. You know, we were able to see if we met our benchmarks for our grants. We also use the Survey Monkey. We also provided parenting using Zoom, and that was well attended. We have 20 participants for parenting, but we only have one who fully completed, which, you know, but that was to be expected. I'm just happy that we got, you know, I would consider ourselves successful in getting all of this done in the 2 years that, you know, the pandemic has been here. Hasn't been easy. It's you know, a lot of work, a lot of planning. We've also started support groups for, we have one on the North Dakota side that was developed by the youth coordinator, and she called it her grandma group, because we have a lot of grandmas that are raising grandchildren due to the opioid pandemic, the opioid crisis. We have a lot of grandmas, so she started a grandma support group. And one of the things that they are working on is getting a code developed, because we don't have anything in our tribal codes for opiates, for meth. So they're working on that. That was one of the things that wasn't the purpose of the support group, but that was one thing they talked about and that they're working on, and hoping to get that through our tribal system. And then we also have another support group on the South Dakota side, in the McLaughlin area. They chose the McLaughlin area and the Fort Yates area because they're kind of like the central hub of the reservation. Like I said, we straddle both North Dakota and South Dakota side. So they chose those two communities with the bigger population. And that support group is well attended. Out of those two support groups, we've had some young people that are into recovery that want to start NA group. And so we're happy to help them begin that, and they can use our one of our facilities to start the NA group. So I think, once we started all of this, it just kind of snowballed, and we have other, community members that want to help. We've also did a recovery walk. And we walked from our treatment facility into the town. It was like 5 miles. We did that walk. We had the veterans. The veterans started off for us. And then we ended the walk at our tribal administrative building. And then we had like 5 guest speakers that have been in recovery for the past 2 years tell their story, and that was well received. But yeah, the MAT, it was a process. We have weekly meetings through Zoom with Dr. Bearstill. We haven't had any since the summer began because we don't really have any updates. But we keep in contact with her. We keep in contact with the court. We have we are also hoping to get a coalition, a sober coalition or a recovery coalition started on our reservation. We just have a lot of things that we brainstormed and hope to start, all because of the pandemic. I think it was kind of a blessing in disguise that this pandemic hit us, because we were able to plan all of these and get him working on our reservation. But that's all I have. I mean, I'm not an expert. Like I said, it's been a work in progress. I was happy to be invited here because we're all very passionate about prevention, MAT, and helping our folks get sober, because we need it on our reservation. And I know it's not only our reservation, it's across the country that we have an opioid problem. We have a meth, heroin, fentanyl. With the tour grant, I attend a lot of their webinars that they send out weekly, and I attended a lot of those, and I get ideas from other tribes. I was able to purchase fentanyl test strips and get the training on that, and we're going to go out into the communities and distribute those, train the public and give them out if needed, if they want them. But yeah, that's all I have.
Thank you. Can you all hear me? Attendees online, can you hear me?
Yes.
Yes, okay. So that concludes Alvonne's presentation. Do we have any questions from online attendees? Or those in person?
I have a question. I may have missed it, but do you work with the court system?
Yes, yes, we do work with the court system. We have meetings with them. They send us referrals. We wanted to go into the jails and do assessments, provide assessments, but due to policy, we weren't. So we're hoping to change that policy, but due to policy, we can't go into the courts or to the jail and do assessments.
Is that with all the 5 areas you alluded to? The districts?
Yeah, we only have one court system, the tribal court system,
Oh,
and they have jurisdiction over the entire reservation,
thank you.
unless they're non-native.
Thank you.
Mhm.
And we had a question from in the room.
Yes, the criminal testers do explain that process.
They're just like they're just these little test strips. They're kind of like the COVID strip. We can give them out to the public. They can test their yeah,
Saliva?
their drug.
Oh,
It's
they're
what- yeah.
testing the drug itself.
Yeah,
Oh, okay.
yeah. So we give those up. We give those out to the public. Part of the harm reduction efforts.
So I just received a question online. Do you offer an opt-out screening program?
I'm not sure what, we offer outpatient. It used to be 9 weeks, but we extended it to 11 weeks through telehealth. And it's 4 hours a day.
Another question, have you experienced health insurance challenges in the program's HIV and hepatitis C prevention efforts for individuals with opioid use disorder?
Well, most of our clients, like I said, they lack income. And we primarily utilize IHS where they're not charged. Or if they, we refer them off the reservation, we help them get Medicaid, or we ask them if they have Medicaid. We did get a memorandum of agreement with 2 facilities off the reservation, 3 Rivers in McLaughlin area on the South Dakota side. We did an MOA with them that we will pay for any tribal members assessment if they choose to go to 3 Rivers. As long as we have the paperwork in place, we will pay for their assessment. And then we also did an agreement on the North Dakota side with another private provider.
I have a question. So when the tribes were distributed the CARES Act money and ARPA money from the federal government, did you see an uptake in crime and drug and alcohol use
Yes.
in your, on your observations, and how did that impact you and your ability to address the need?
The calls slowed down after our tribe gave out a $2,000 incentive for tribal members who received the vaccine. But surprisingly, there wasn't a lot of our clients, they refused the vaccine due to all of the misinformation about the vaccine. And then they also gave out a hardship payment to members 18 and over in the amount of $4,000. And after we, a lot of the tribal members received that, our calls slowed down, our calls slowed down, our referrals slowed down, everything slowed down, and then crime went up.
Does the Indian Health Service provide the
Suboxone.
Suboxone, or do they go through your program?
IHS provides the Suboxone.
So between yourself and anyone else in the room, I understand the benefits of providing Narcan and the fentanyl testing strips with drugs. Have you seen any more of an uptick in drug use since providing those? I can see it as almost an encouragement and kind of a safety net for drug users, knowing, oh, we have Narcan available, we have the training, we have fentanyl strips. It's almost making it safer to use, but also I understand that it's saving lives in the process. Are we more in the mindset that if they're going to use the drugs, they're going to use them whether there's fentanyl strips or Narcan, regardless? And is that what you've seen in your tribe here?
Yes. We get a lot of tribal council members or any elders, they don't understand harm reduction, so they think we're just promoting more drug use. We're not. We're trying to save lives. We're trying to, like I said, we did have the 3 ODs on our reservation, and that was enough. And they were all young, real young, maybe in their early 20s. Our life expectancy on the reservation is getting lower and lower. And that's why we hired the tribal opioid the specialists to go out there and educate our elders and our community members on harm reduction, MAT, and support.
I have a question on your specialist. The credentials does that personnel. She has a process that we have to but here's a point,
You're hoping to hire more, you need more males. Hoping to hire at least 1 male.
how many dances you choose for how is it quiet or you do not have to. You just do not know. Okay, so what we can first. Oh, are you a 638 program? So were you awarded with ARPA? I know that there was there was a pool of money for behavioral and mental health services. So what are you? Did you utilize that? And cases for, because it's COVID based. Yeah, we did get an emergency COVID grant under our program, but, another program was not on that. We were providing emergency services to, community members and to our providers.
Oh, okay.
I'm sorry. Can everyone hear now? Yes, online, are we good now? Thumbs up? A yes, chat? Thank you. Oh, they want you to test. Can you say something?
Yeah, can you hear me?
Got it, thank you. Do we have any additional questions for those that are online? I want to make sure that you all feel included in the conversation. Any additional questions in the chat room? If not, that concludes